8th installation ceremony.
Not yet, sir.
FEFCON പ്രൈസ് കിട്ടിയ ആൾക്കാരുണ്ടല്ലോ, ഒരു ഫസ്റ്റ് 2 സെക്കൻഡ് കിട്ടിയത് നമുക്ക്. നമുക്ക് അന്നവർക്ക് പ്രൈസ് കൊടുക്കണം അവന്റെ ഇൻസ്റ്റലേഷൻ മീറ്റിംഗില്.
Let's start, sir.
വിജയമോ ജോയിൻ ചെയ്താ? Okay, then we can start. വിജയമോ തുടങ്ങാം നമുക്ക്. Very good evening. A warm welcome to 11th series of meeting of Thrissur Talk series on infection, immunization, and antibiotics. So last time we had an excellent talk by Dr. Kashi and his team on COVID vaccination. And now we covered almost half the topics of the infectious disease. And next coming month, we'll cover the other topics also. All topics are well attended. And I would like to welcome all the IAPNs, members of the IAP family. First, our chief guest, Dr. Vijay Umar, he is the president-elect of IAP and my own classmate, roommate, and I have great pleasure to welcome Dr. Vijay Umar. I would like to welcome today's speaker, a great academician. I think I heard Suresh Kumar's talk many times. All are very impressive and very, from his study only, his experience. I think we really will get. I think we have a great academic feast. I welcome Suresh Kumar sir on behalf of the IAP Thrissur. I welcome our own person, Dr. Riddhi Shandaguma, and also Dr. Ragesh, President, and also President-elect, and also one VIP, Sadish Narayanan, Deputy DMO from General Hospital, and our Secretary, Dr. Sijit, and incoming Secretary, Dr. Pawan Madhusudanan, and also Head of the Department of Pediatrics, Parvati Madam, Dr. Shiva Prasad, Anju Deepak, President of Infectious Disease Chapter, and all other DFs. Now I request Dr. Riddhi Shandaguma to give her presentation.
Good evening, everybody. Am I audible?
Yeah.
Okay. So good evening, one and all. We all gather together as the curtains close down on the year 2021. The topic today is a very relevant one, that is antibiotics in office practice. It was in 1909 that Paul Ehrlich discovered a medicine to treat syphilis. Fleming discovered penicillin and the world rejoiced. But unfortunately, along with it came another threat, antibiotic resistance. Today, we are really very delighted that an expert in the field of infections, that is Dr. Suresh Kumar, will talk to us on the rational use of antibiotics to tackle this resistance threat. With us today for the meet are honorable guests, that is Deputy DMO Dr. Satish Narayanan, the incoming IAP State President Dr. Vijay Kumar, the Chairman of the State Antimicrobial Resistance Program Dr. Shiva Prasad, District Nodal Officer for AMR Program Dr. Pavan. Though Dr. Anandakeshwan has already welcomed them, a warm welcome on behalf of Thrissur IAP. Coming to the activities of our branch, our last activity was a panel discussion on COVID vaccines. It was very well appreciated by the audience. Upcoming now on January 8th is the installation of the new office members along with a family New Year bash at Das Continental. Request all of you to attend in full strength. Also, we have the National Tuberculosis Eradication Program. We will be holding it on January 30th. I'm very proud to say that for our state pedicon, many of our members came back with awards and laurels for our branch. Congratulations to each and every one of us. Also, from 16th to 20th of Jan is our national conference. I'm very proud on behalf of Thrissur IAP to be going along with a few of our members as we have won a lot of awards and will receive it personally. So also coming up in March is our NNF conference, our international conference in March. I request every member to enroll for this conference. So I conclude with Jai Thrissur IAP, and I now humbly invite Dr. Vijay Kumar, our incoming state IAP president, to inaugurate today's program.
Respected senior faculty members, Dr. Anandakeshwan, Dr. Suresh Kumar, the speaker, and all the distinguished guests and my dear friends. It gives me immense pleasure to be here for the 11th topic series of infections and immunization hosted by IAP Thrissur. I think this is the most sought after series of topics in the year 2021. And I expect similar wonderful programs by Thrissur IAP in the coming year also. And regarding the topic, the antibiotic policy and office practice, that is a very relevant topic for pediatrician and general practitioner, because there is an emergence of antibiotic resistance and no new antibiotics are there in the pipeline. So we have to use the antibiotic very carefully to prevent antibiotic resistance. And I extend my gratitude to Thrissur IAP for giving me a chance to be there in this program and also selecting a very important topics, a must-know topic for pediatricians. Thank you. Jai Hind and Jai IAP.
I request Dr. Satish Narayanan to deliver his keynote address. He is a deputy DMO of the Thrissur, and also now government policies that they do. Every hospital got an antimicrobial resistance committee, monitoring committee. I think Dr. Pavan Masoon is a nodal officer here. We got a state officer, Dr. Shiva Prasad here. So I welcome Dr. Satish Narayanan to deliver his talk.
Thank you, sir. Good evening, everybody. First of all, thank you for inviting me to this highly informative session. And it's very happy to know that IAP is conducting an important session on such an important topic today. And I personally know Dr. Anandakeshwan sir and Dr. Pavan Madhusudanan, but a few of the others I don't know personally. Still very happy to be here. And all of us know how to treat, but it's more important to know how not to treat. And you are important to learn the do's and also the don'ts. And antibiotics are a double-edged sword. We have been using antibiotics ever since our birth, but a few of us, or many of us, have been using it occasionally injudiciously. The use and misuse of antibiotics have been an issue of great concern. We all know that many deaths have been occurring due to the burden of antimicrobial resistance. The total number of deaths due to antimicrobial resistance is coming up to around 7 lakhs each year now. And this is bound to go up in the coming years. And it is expected to reach 10 million by the year 2050. So we need to act now to save our coming generations from the burden of antimicrobial resistance. It is because of injudicious use, lack of patient compliance, and the vast global trade and travel that the burden of antimicrobial resistance is increasing day by day. So in the coming years, especially in a state like Kerala, the problem is going to be worse and worse. So I request all of you, including myself, to be part of this campaign. We have been organizing classes in all our major hospitals regarding antimicrobial resistance. And I think day by day, people are, especially doctors, are getting aware of the threat of antimicrobial resistance. Nowadays, anyone can buy any antibiotic at any medical store and use according to their wish. And this practice should be stopped. And we should be using antimicrobials judiciously. And I hope everyone will be part of this campaign and will be successful in spreading this awareness to the common public. And I once again thank all the faculties here for inviting me. And I wish you all a very happy New Year. Thank you, sir.
I request Dr. Shivaprasad, the state nodal officer for the AMR program, to give a felicitation. Over to Shivaprasad.
Thank you, sir. Respected seniors, my dear friends. Actually, it's an exemplary work done by this Thrissur IAP team. A lot of series, more than 10 continuous series on AMR action plan. And we all know that Kerala is the first state to release AMR action plan. And we are going to implement our state level action plan in our all districts. And Kerala antibiotic literature state by 2023. This is our aim. And IAP is the strategical partner to government to implement AMR action plan. And we also very happy that we won the first prize at the national level for our activities we done related to antimicrobial resistance. And lot of AMR champions are coming from our IAP, and Anandakesavan sir is on our leading role. He is actually a master in AMR action plan implementation program. And I congratulate the IAP Thrissur team for this exemplary work, and also request them to continue this momentum as Vijaykumar sir told. And also, I wish all the best wishes for this program. Thank you.
Dr. Bashir, mute yourself. Now I invited Dr. Pawan Madhusudan, a nodal officer for the AMR program for Thrissur district. Pawan.
Yes, thank you, AK sir. So I'm very happy to be part of this very relevant CME. I once again thank Anandakesavan sir and IAP for organizing this program. Recently, I was requested by DMO Thrissur to organize the AMR activities in Thrissur district, and it was on the right occasion. AK sir has planned. He had already planned to conduct a program on AMR resistance. So I wish the Thrissur DMO, in association with IAP, can move forward with all the AMR programs in the state, and at the same time we can go on with the IAP state action plan for the AMR program. Thank you. Thank you once again and best wishes for the CME program. Thank you.
Now, I invited Dr. Anju Devak. Anju, State Infectious Disease Chairperson. Yeah.
Good evening.
Yeah.
Sorry for joining. I'm actually in the IAP Trivandrum meeting. That's why I'm not switching on my camera. Good evening, respected Vijay Kumar sir, Anandageshwan sir, Riddhi madam, Dr. Srijit, and all dignitaries and fellow IAPians. I'm extremely happy that Thrissur has done an exemplary job as conducting an infection series, and the whole series was welcomed well and attended well. They have covered almost majority of the topics in infection, and it is a very good topic chosen this time. Very relevant for the times when we are abusing and misusing antibiotics. I hope at the end of the day today, we'll all take the message where not to use antibiotics. And I think that's very important for the young pediatricians to understand that. I wish all the best to Thrissur IAP to come out with excellent programs in the coming year also. Thank you.
So thank you. Now we'll move on to scientific session. As such, today's topic is judicious of antibiotic in office practice. Antibiotics is the most common drug used, misuse, abuse, and overuse. We are using the right and left. We are using it as an antiviral. We are using it as an antifungal. We are using it without any purpose also. I think four important conditions where we are using antibiotic, abusing antibiotic. One is viral fever. Second one is upper respiratory infection. Third one is diarrhea. Fourth one is most common is asthma. Because any asthma patient will get some crepitation, so you're forced to give antibiotic. When you are taking an X-ray in asthma, you'll get some shadow here and there. Again, you will put on antibiotic. So all these things are very common. And also, we are not following any guidelines. That is why I invite special infant Suresh Kumar, a very important key person in this aspect, because we are following our own guidelines. Also, we'll get all types of combination here. We'll get a 2, 3, 4 drug combination, 2, 3 drugs, agonist, antagonist, all drugs will get a system. We are getting poor quality drugs. So all this will lead to antibiotic resistance. And we are not against using antibiotics. Whenever there is a sick children, we have to use antibiotics. But using third generation or high-tech antibiotics for simple community pneumonia or a common infection, I think we have to avoid this one. I think Dr. Suresh Kumar will deal with all these aspects. Dr. Suresh Kumar is MD and FFNB in infectious disease, the American Certified Tropical Medicine, and also his fellowship of HIV AIDS medicine, and also he's co-founder of Best Infectious Disease Simplify ID also. And a young investigation award from International AIDS Society. He got so many awards also. And Professor S.K. Rajan Gold Medal Award, travel awards from infectious disease from Geneva 3 times. And he also expertise in tropical infections, nosocomial infection, and more than 40 publications in indexed. Well, we can see when he got many his articles also, we can see it. And so I think we are very lucky to have Dr. Suresh Kumar here on behalf of the IAP Thrissur and my personal behalf. I welcome you, sir, to give the lecture. Over to Suresh Kumar, sir.
Thank you. Thanks for inviting me as well as your kind words of introduction to me. So I sincerely thank the IAP Thrissur branch for inviting me for this talk, and in particular Dr. Anandageshwan for inviting me for this talk and kind words of introductions. So as you rightly pointed out, Antibiotic Awareness Week is going on the November 3rd week of everywhere across the world. But we celebrate a little late before 2022. We are celebrating antibiotic choice in office practice. We are going to do case-based discussions only. So my disclosures, I don't have any shares in any of the pharmaceutical companies, and my today's talk is not influenced by any of the pharmaceutical companies neither. And people always say children are small huddle, but definitely not so. Children are not small huddle to me. They're different specialty, even though I deal children's and infectious diseases in Apollo hospitals, but usually I do adult practice and I do pediatric practice also. So children's are definitely not a small huddle to me. So my objective today is rational thinking of antibiotics, because ritual is more common. Everybody ritually they want to use it. Parents are insisting to use antibiotics, and sick some other time when we do not know the diagnosis. When fever is striking, we want to use the antibiotic. Rightly pointed out by previous speakers. So when not to use antibiotic is a big challenge. Using antibiotic, everybody can use it. But when not to use antibiotic is a big challenge. So I'm going to rationalize my antibiotic choice. What I'm going to show a couple of initial slides, and I put a couple of common case scenarios, what we encounter in our day-to-day practice. Before I start, I just want to see, right now 57 participants were there. So how many fever patients see in OP? I'm just asking fever patients in the OP settings. I'm not asking IP setting. I'm not asking other cases like your immunization cases and other thing. I'm just asking fever patients in your OP. You are starting antibiotics. Just put it in the chat column so that we know whether you are attending your sessions or whether your system is attending the sessions. We can able to find out. Please go ahead and vote. 10 on 10. Suppose if you see 10 patients in the OP with fever, all 10 patients you want to start antibiotic, yes, please go ahead. Or 5 out of 10 patients, I'm going to start antibiotics. If the child is presenting with fever, 2 to 3 or 1 out of 10 or 0 out of 10. So I just like to see a couple of responses initially happen. Please go ahead. So people say 2 to 3, people say 3 or 2 to 3. That's a common response. So antibiotic abuse is not happening among the participants of today's sessions. So I think the session is really needed because we people are aware not to use antibiotic, but sometimes this is a bit difficult, even though we say here, but in the real scenario, it's difficult to avoid antibiotic prescription sometimes. So we know the antibiotic, the first antibiotic that showed the success rate is in the pediatric. This child at the age of 5 years presented with a severe necrotizing fasciitis. She underwent almost all sorts of treatment at that point of time, but no response. Fortunately, penicillin came into the market. The child received penicillin within 5 to 7 days. The child became a queen. She lived up to the age of 90. She gave a famous interview at the age of 2008 saying that penicillin saved my life for 85 years. So this is a real magic bullet of 1940s, 1945, 1950s I put antibiotics were powerful. I'm not telling antibiotics are powerful or antibiotics is going to be powerful. For me, the antibiotic is losing the magic. The antibiotic lost the magic bullet power. Previously, when you start antibiotic, for example, any urinary tract infection, if you start an antibiotic, the person responds like anything. How this child is responded now with antibiotic. In fact, this gave confidence to World War soldiers too. Go and fight. Whatever injury you are sustaining in a World War II, the antibiotic is there. It's going to keep you, it's going to alive. Whatever injury you are going to sustain is going to heal your injury. So that gave the confidence. So the antibiotic success story was invented in the children. So they demonstrated antibiotics were a powerful tool. Unfortunately, after seeing this powerful tool, a lot of abuses also happened. So this is one of the case I'm going to discuss today. 5-year-old male child is basically from urban area, Chennai, fever of 4 days durations. This is you consider pre-COVID era, not COVID era case. So don't want to flush with the COVID era. Sore throat of 4 days, cough, dry cough, no shortness. And particularly this is not an Omicron era also, because this is classic case of Omicron. People consider fever, sore throat, cough. Nowadays, Omicron is behaving like a cough and cold and sore throat. So don't think this is this era case. This is 2019 era case. So no shortness of breath, no chest pain. On examination, the vital was stable, conscious, oriented. Throat is mildly congested. Respiratory system, normal vesicular breath sounds, no added sounds. What will you do now? Because I keep on asking the question, so we need to have been interactive rather than monotonous actions. Start antibiotics. How many want to start antibiotic for this child? 4 days fever, congested throat, respiratory system examination is normal. Tried some symptomatic therapy for 3-4 days, no response. Now coming to you, whether you want to start antibiotic or you want to investigate, or you give symptomatic therapy or start antibiotic along with symptomatic, along with investigations. Everything you want to do. Now 4 days is over, or get some specialist opinion why the child is congested throat. Please go ahead and vote so that we can see. So people are answering mostly 3. They want to give symptomatic therapy. So well-learned audience I'm attending now. Before that, I'll come back. So the antibiotic choice. Sometimes our choice may be not correct. So people always feel this choice is not correct, that choice is not correct. And rightly point out my chairperson, clearly told there is no clear-cut guidelines. A lot of guidelines available. For example, American Academy of Pediatrics, Pediatric Infectious Disease Society, a lot of guidelines are available. But to adapt for Indian situations, we need to have a good Indian data to adapt our Indian guidelines. It is lacking now. Even Google will not answer for you. These are all the guidelines. So what I'm going to do next 20-30 minutes, what are all the steps we need to follow in antibiotic selections. And we need to have some tips also and common examples I'll go to give and summarize at the end, and way forward I'm going to discuss with you people. So first thing in rule, infectious disease or any setting, whether the child presents to you, you need to assess whether the child is stable enough for further assessment or the child need to be stabilized. That is the most important and vital thing. Before write antibiotic, before write diagnosis, assess the stability of the child. And assess the stability, how adults we use called Q-SOFA. Vital parameters, out of 3 vital parameters, respiratory rate more than 22, systolic BP less than 100, not able to give history, conscious or confused. That point of time, we will say the patient is not fit. Similarly, in child prostrations, similarly, the respiratory rate, depending upon the age, the respiratory rate should above the upper limit of the normal. Similarly, the BP also, according to the age group, the BP, it's not a systolic BP of 100. In pediatric setting, according to the BP, what defined, if it is lower, minimum 10 to 20 millimeters lower, the child is dehydrated, not able to sit, not able to lie, the person is not able to have a high-to-high contact. That point of time, the child should be stabilized first. So the mantra in antibiotic selection, stability of the person or stability of the child is more important. That is more important. Step 2, most of the time the anxious parents will tell the child has got fever. If you ask what is the recording, they will say 96, 97, 98. So they won't tell this is fever, but they always touch the child and see the child is warm. But if you see the child is active, playful, the child will be very energetic. But if the parents keep on complaining, the child is having fever. So the second mantra, the parents complaining, particularly the anxious parent, only one child they're having, it means they're very anxious. So they always says the child has got fever, the child is tired, the child is having cough and everything the most of the time. But we assess a child for 5 to 10 minutes on OPD settings. The child is very active, energetic. That amount of infections won't present. Suppose the child is significantly harboring some infections, definitely it won't be there. Suppose it's given some paracetamol before brought to the clinic, sometimes the activity during afebrile phase will be there, accepted. But we know how the child has taken the food in the morning, breakfast, whether active, playful, watching TV. This is possible. So don't go by with the parents' words. Ask them to write a chart. The simple temperature chart will give more idea rather than the history given by the parents. So ask them to write a temperature chart. That is more valuable. Some of the exceptions, for example, extreme newborns, extreme preterm infants, sometimes don't expect fever to be present. Similarly, elderly people above the age of 1995, immunocompromised host, people taking steroid for some other reason, you don't expect fever to be present. So fever is alone not the criteria, but the patients keep on complaining, the parents keep on complaining, record the temperature. That is more important. Then everybody knows there are 5 moments of hand hygiene. Before touch the patients, before any aseptic procedures, after the body fluid exposures, after touching the patients, and after going to the patient's environment, we need to do hand rub. This is a WHO 5 moments of hand hygiene. We need to know there are 4 moments of antibiotic writing. Before you write the antibiotic, please ink your diagnosis. What is your diagnosis? People write viral fever, they're writing antibiotics. If you write viral fever and write antibiotics, some other doctor sees your prescription, they think that you're not aware of antibiotic prescriptions. That's a simple thing. We do a lot of OP antibiotic audits. If you see the OP antibiotic audit, they write viral fever. Viral fever, the next thing they write antibiotics, amoxicillin will present automatically. So if you write a diagnosis, if the diagnosis requires some antibiotic, for example, most of the OP diagnosis, for example, acute respiratory tract infections, upper respiratory tract infections, common cold, these does not require antibiotic. That is a mantra. So when a child is stable, the child is fit enough to manage in the OPD and presentation is 2 to 3 days, definitely the child does not require antibiotics. For that, how to prevent it? Write your diagnosis. If you write a diagnosis, most of the time it is not required. Second thing, if you really want to start an antibiotic, we need to ask your questions whether I need to send some appropriate sample or not. Most of the outpatient settings, stable child, there's no need for any major investigations, maybe simple on blood count investigations. If required, you are really worried about some imaging in the form of X-ray test may be required. Otherwise, most of the children in outpatient setting, up to 3 days, even up to 5 days for well-looking child, we doesn't require any major investigations. Third thing, suppose if you start an antibiotic, we need to ask whether the daily we need to reassess. So the child is coming for follow-up. What is the earliest phase I need to cut down or we can narrow down? If we start 2 antibiotic to cover something else, but when we know when the organism is not present, we need to narrow down. And the fourth mantra is more important nowadays. Previously, we used to treat longer. For example, sinusitis, if you read the guidelines, we need to give 10 days of antibiotic therapy. But now the guidelines has come down to 5 days of therapy is fine. For most of the infection, the thumb rule is 3 to 5 days. Even for community-acquired pneumonia, 3 to 5 days is fine. And similarly, for urinary tract infections, 5 to 7 days is fine. So the thumb rule is more than 5 to 7 days is for most of the infections. For outpatients antibiotic, hardly 3 to 5 days is more than sufficient. Don't overshoot the thing. Short is sweet for antibiotic. That is most important thing. So before write an antibiotics, what we need to know the syndromic diagnosis. This is very difficult to make an accurate diagnosis. We need to make a syndromic. For example, the child has got fever, running nose, sneezing, sore throat. It is upper respiratory tract infection. Some hoarseness, otherwise laryngitis or pharyngitis. So we can put either pharyngitis or pharyngotonsillitis. If you write pharyngitis or pharyngotonsillitis, why I want to write the syndrome? That's a question people are asking. If you write pharyngitis or pharyngotonsillitis, what causes pharyngitis or pharyngotonsillitis? 85% of the time or 90% of the time it is due to virus. What bacteria we are worried about it? Group A beta hemolytic streptococci. Why we are worried about it? Because it can cause rheumatic fever. So that's the only bacteria we need to worry about it. So to differentiate viral and bacterial, we need to write the syndrome. If you write pharyngitis and pharyngotonsillitis, it is most likely pharyngitis, pharyngotonsillitis is viral. Similarly, the child presents with fever, diarrhea, so watery stools, no blood, no mucus, 3 to 4 episodes, and well-looking child, no fever. It is gastroenteritis. If you think gastroenteritis, it's again mostly virus. Either rota or whatever viruses is common, that's going to cause sexual diarrhea. So there's no need for any antibiotic. Provided the child is stable, the child is hydrated well, and no fever, the loose stools episodes is 3 or 4 times. There's no need for any specific antibiotic. On the other hand, if you write a diagnosis of urinary tract infections, when you think the child has got UTI, we need to send appropriate sample. Appropriate sample is urine routine along with urine culture. Never write urine culture alone. Whenever you want to do a test for suspected UTI, please send urine routine. Why urine routine? If suppose a child is not able to give the history of burning sensations, usually 2 to 3 years child, if you ask the parents, they will recognize. At the time of passing urine, the child will show some discomfort, whether the mother recognizes it or not, whether the mother notices it or not. Some grown-up children like 4 or 5 years automatically will complain. 2 and 3 definitely show signs of some discomfort in the face. Only very newborn or infant is very difficult to differentiate. That point of time when the suspicion is high, what is required is urine routine. If urine routine does not show pus cells, don't treat the urine culture. That's most important thing. We need to keep in mind. So we need to write a syndromic diagnosis. If you write a syndrome, what is the appropriate test to confirm the syndrome? Whether the syndrome requires antibiotic or not, we need to decide about it. Then the fifth step, what we call is use your test. Use your test. Most of the tests, what is required in outpatient setting is one complete blood count. If at all, malaria is not gone down. So particularly the dengue is more common compared to the malaria. So don't think still malaria and giving empirical anti-malarial. That is all outdated concept nowadays. So if the child is having fever, history and physical examination is more important, followed by basic tests. Basic tests in the form of complete blood count will give more importance. I told earlier, urine routine is very vital. And if at all, suppose a child has got cough or shortness of breath or some difficulty in breathing or tachypneic, we need to do X-ray chest. With this basic investigations, we can be able to figure out what is going wrong with the child. So practical tips I've shown the step. What are all the steps? First thing, assess the stability of the child. Second, confirm the fever is present or not. Third, write a syndromic diagnosis. In the syndromic diagnosis, you need to know what is a syndrome, and we need to know what appropriate lab test to be do. Then we need to know proper history taking. Suppose a child came with a fever, we need to ask where they went, what they did, what sort of food they're eating, any sick contact in the family. Because once a child is sick, other child is also sick, that means mostly viral. So we need to elicit the history of sick contact. Similarly, the previous antibiotic, your colleague has written some antibiotic, see the antibiotic. What antibiotic the child has received. Despite receiving, for example, the child received azithromycin. Despite receiving azithromycin for 5 to 7 days, the child is having fever. What are all the things it rules out? Chances of leptospirosis, chances of scrub typhus, chances of typhoid is less likely. So we need to know what is the prescription the child is receiving. We need to go through it. That's more important. Then we need to find out any localizing signs and symptoms, because I told we need to make a syndromic diagnosis. how the syndrome is making. We need to listen the symptom, we need to look the signs. So look for signs and symptoms, and we need to go because children are fond of pets. Pet exposure and travel. But fortunately, during the time of COVID, the travel is not great. But half late people start traveling back again. So history of travel, where they went, what they did, and most important. And particularly for some of the children, they got some of the steroid exposure. For example, they are taking steroids for Sogia or some connective tissue diseases, what they're thinking about it. And history of hospitalizations, particularly child hospitalized for recently, definitely exposed to antibiotic, and antibiotic resistance is very high. Some of the children are sick like cancer patients and immunocompromised patients. We need to think about it. And more important, previous drug or previous antibiotic history. What sort of host we need to know, whether the child is coming from the community or the child has been recently hospitalized. What she is doing. So the child is going to the school or attending the schools from the home. What is a new thing? What is a recent recognitions? Any weight loss significant? These things are very important to me. And we need to do the head-to-toe examinations. We need to look for rashes. We need to look for the glands. We need to look for the tonsils, and we need to look for any swelling any other part of the body. We need to examine. And more important, respiratory system examination. Look for crackles and look for any murmurs also in the cardiac respiratory system. So look for the joints, look for the respiratory system, look for the cardiac system, look for the rashes. These are all the vital things, because the syndrome based upon the symptom as well as sign. So try to get, particularly during the month of August to February, particularly from the rural background or exposed to the bushy area, look for eschar. If you find an eschar, the problem is solved. There's no need for any antibiotic. For example, the ceftriaxone will not work. So we need to check for it. And we need to know what is the appropriate test. The right test, for example, the antibiotic also has got 4R. Right patients, right drug, right dose, and right durations. Similarly, for the test also, right test, what is the appropriate specimen, what is the turnaround time, and what amount of blood or what amount of tissue we need to send, that we need to remember in mind. For example, if it is an upper respiratory tract infections, pharyngitis or pharyngotonsillitis, mostly virus, there is no need for any specific test. If you got access to the rapid step screening, that's fine. But otherwise, culture means 48 to 72 hours, a bit difficult. Similarly, if the child has got urinary tract infections, urine routine is vital along with urine culture. If it is gastroenteritis, mostly there is no specific test is required. So depending upon the organism, depending upon the syndrome what you are making, you need to do the basic test, and to confirm the test, we need to take appropriate sample at appropriate timing also. That is more important. For example, if you are thinking malaria, don't give malaria as a prophylaxis. People previously used to take peripheral smear and give chloroquine, but now malaria has gone down. So if you want to make a diagnosis of malaria, take peripheral smear, because there is no clinical way we can. Fever, chills, and rigor, fine. But nowadays, fever, chills, and rigor is missing. So go for peripheral smear. Similarly, dengue. If you think the child has got dengue, what day the child presents to you? On day 1, the child is presenting to you, you can do NS1, because the NS1 is an antigen equivalent to your RNA. So it is present in the first 2 to 3 days. After 2 to 3 days, the NS1 will disappear. IgM will need minimum 4 or 5 days to form. So the child presents to you on day 3, day 4, you do the test called NS1 and IgM. NS1 formed, disappeared. IgM is not formed. But the classic presentation, the child has got fever, the child has got sudden onset, pain behind the eyes, headache, back pain, rash will be present. So everything towards a dengue. But if you see the dengue test, NS1, IgM negative, what it indicate? We are doing the test on day 3 to day 4. That point of time, NS1 has disappeared, IgM is not formed, but a child is having the infection. That's more important. Similarly, typhoid means people want to do Vidal. Vidal is an useless test to me. Why? We need to do 2 Vidal. Based upon 1 Vidal is very difficult to say, because what is a significant titer? No studies has been conducted. We need to do 2 Vidal, rising trend 4-fold. First Vidal at day 5 to day 7, or at least on day 1 of the presentations, you do a baseline Vidal, and on the day 7 again you repeat on Vidal to see the 4-fold rise. But the child needs to wait minimum for 7 days. This is, people don't accept the thing. On the other hand, blood culture is fine, but blood culture again will take time unless we use an automatic system. For example, in our hospital automatic system, in automatic system, I can be able to recognize it on daily basis. It is not 5 days, 7 days time. I can call the microbiology lab, any culture growth. Yesterday I sent a blood culture, any bacteria is growing or not. But the simple thing is do the CBC, look for the eosinophil count. When the eosinophil count is missing, see the neutrophil count. Neutrophil count is normal. Eosinophil count is missing. Erythrocyte sedimentation rate is normal. WBC count is normal. It is most likely typhoid. Scrub typhus means usually the WBC count will be elevated. So we can do the scrub IgM ELISA. But again, all serological tests, we need to wait minimum 5 to 7 days. So don't do the serological test between day 3 and day 4. Leptospirosis, again, we are doing PCR. Nowadays, PCR is also available. If PCR, you don't have access, you do IgM, but you need to wait for little longer, 5 to 7 days. Sometimes leptospirosis, even 9 days also will take. Influenza, people want to use RT-PCR, not recognizing antigen test. Dengue, depending upon the timeline, whether NS1 or IgM, or you think secondary dengue, what will happen in secondary dengue? NS1 and IgM will form, but the intensity of IgG is much higher. So straight away IgG will present, NS1 and IgM won't present. So we need to know what we are doing. That's most important thing. For TB means people used to say MAN2. There is no role for MAN2. Particularly for children, if you're given a BCG vaccinations, MAN2 will remain positive. I have seen a child today, 1 year old child, 1 year, 2 months old child, referred to me because they did a MAN2. MAN2 shows 25 millimeter surrounding. I told even 25 millimeter, 20 millimeter, it is not better. I repeated the TB quantiferon gold. Quantiferon gold is negative. MAN2 has got cross reactions with BCG vaccinations. So children who got vaccinated up to 5 years minimum, the MAN2 remain positive. Whatever be the value, 2 or 5 or 20, it's not matter. And even if it is positive, it will say latent TB. It won't say active TB in the child. So if you want to make a diagnosis, we need to go for expert MTB PCR. That's called nucleic acid amplifications. Nucleic acid based amplification test we need to do. So that is mandatory. Don't go with the MAN2. So what are the tests I'm not doing? Viral I'm not doing. MAN2 I'm not doing to make a diagnosis of it. HIV means we need to go with the 4th generation ELISA, but we need to wait for 18 months because mother is positive. Passively the antibody can go to the child. So we need to wait for minimum 18 months for the passive antibody to disappear. If you do little earlier, negative, that is got fine. But positive, don't tell the child is positive with HIV. Urinary tract means you need to look for the signs and symptoms, particularly you need discomfort. In the first 3 to 6 months is very difficult, but even smart mother can notice the child has got discomfort while passing urine. But after the age of 2 and 2.5 years, mostly if the parents are smart, they can able to recognize the child is having discomfort. 4 and 5 years child, mostly they come and tell they got some discomfort, they will come and cry, they can put the hand on the lower abdomen, we can able to recognize it. That is more important, but more important, urine routine. If urine routine, absence of pus cells, urine culture more than a lakh colony of copies, just ignore it. And acute gastroenteritis, mostly no test, but if you do the stool routine, pus cells is present, again it may indicate bacterial infections. I'll come back on how to deal with the gastroenteritis bit later. But if you want to stop the gastroenteritis, one test is available right now. One is called the molecular PCR, molecular multiplex PCR test. If you do the PCR test, we can be able to recognize 15 to 18 organisms. It contains viruses, it contains bacteria, it contains other organisms also. If you do the test within 1 hour, I know what is organisms. But if you tell the parent, I got one test, gastroenteritis, beautiful panel, within 1 hour, I can tell the answer, the diarrhea will stop. How? The cost of the test is $15,000. If you say $15,000 for diarrhea, automatically the diarrhea will stop. Not only for the child, for the parents also. So we need to know. Similarly, blood culture means we need to take appropriate sample. How much blood, I'll come back and explain a bit later. Adults usually 15 to 20. Even for children above the age of 6 years, same need to taken. So what is the right time to do the test? Fever, usually we do test between day 0 to day 2. No test. 0 to 2, child is stable, no test. 3 to 7 days, minimum test depending upon the symptom what the child is presenting to you. 7 to 14 days, we need to go with the cultures and everything. There is no value. Viral has got no value. MAN2 has got no value. Lepto again for within 5 to 7 days. There is no value. We need to do the test after 7 days. By the time the patients cannot wait. 1 bottle of blood cultures. Usually minimum send 2 bottles. Even in newborn, put 0.5 ml, 0.5 ml in 2 bottles and send. Don't send 1 bottle because sometimes contaminations can happen. To know whether it's a contamination versus real infections, send 2 bottles. That's more important. Similarly, whenever you are sending urine culture, please send urine routine. Without urine routine, never send urine cultures. And what about the bacteria? Why are you insisting to write the syndrome? When you write the syndrome, we are able to recognize what bacteria is causing the syndrome. URI, pharyngitis, mostly virus. UTI, mostly bacteria. Gastroenteritis, mostly viral. Very rarely bacteria. So we need to know. Similarly, how to identify the bacteria. Any infections happening above the diaphragm, mostly gram positive. For example, meningitis. For example, pneumonia, mostly gram-positive, otitis media, even pharyngitis, group A beta-hemolytic streptococci is gram-positive. Anything that is below the diaphragm, mostly gram-negative. Urinary tract infections, intra-abdominal infections, mostly gram-negative. That is why we need to write the syndrome so that I can recognize my bacteria easily without any problem. Then most important thing, we need to know the spectrum of the antibiotics. For example, if you write amoxiclav, that is one of the common antibiotic people are prescribing. Amox will cover staph. Amox will cover streptococci. Amox has got anaerobic cover. That is why even if it is a pharyngitis, tonsillitis, amoxiclav is fine. Amoxiclav has got reasonable gram negative. It covers E. coli, it covers Klebsiella, provided it is sensitive. So amoxiclav is slightly a broader one, but unfortunately amoxiclav, the concentrations in the urine and kidney is not great. Skin and soft tissue it covers because skin and soft tissue, staph and strep. So amoxicillin clavulanic acid covers most of the thing. Suppose if you are writing cotrimoxazole again, it has got good gram-positive cover. It covers staph. Streptococci cover is not great, but staph cover is good. Similarly, it has got good gram-negative cover. It reaches very well level in the urine. Most level in the urine is reaches a thing. So we need to know it has got good typhoid cover also. Amoxiclav also will cover the typhoid. So remember these things. When you write an antibiotic, know what bacteria the antibiotic covers. And within the group, what is the difference? For example, what is the difference between ampicillin and amoxicillin? Ampicillin will penetrate the brain well. Amoxicillin, the penetration of the brain is not great. Similarly, for urinary tract infections, nitrofurantoin, if you see the culture report, nitrofurantoin is working. Most of the pediatric urologists, they want to give you prophylaxis. But nitrofurantoin, what is the drawback? It won't penetrate the kidney. It won't penetrate the prostate. It won't penetrate the upper urinary tract. That is the problem with nitrofurantoin. If you think the urinary tract infection is a cystitis, yes, we can use nitrofurantoin. Nitrofurantoin is a good drug for lower urinary tract infections, not for upper urinary tract infections. So we need to know this pharmacokinetics and pharmacodynamics. And within the group, for example, staph and strep, what are the things covering it up? We need to know the subgroup. Similarly, anaerobes. Amoxiclav has got anaerobic actions. People admitted in the hospital, we are using piperacillin tazobactam. Piperacillin tazobactam has got anaerobic cover. So we need to know what antibiotic has got cover. That is most important. Based upon the coverage only, we need to choose the antibiotics. Clindamycin has got anaerobic cover, but linezolid does not have antibiotic anaerobic cover. People think some skin and soft tissue infections, they want to use either amoxiclav, they want to use clindamycin, linezolid. The advantage of linezolid is available in the syrup form. Clindamycin is available only in the capsule form. So people find it difficult to give clindamycin. That's why they want to give linezolid. But linezolid has got no anaerobic cover. Linezolid has got good gram-positive cover. It has got no anaerobic cover. So these things we need to remember. And linezolid is good anti-TB, particularly MDR-TB drug. Keep in mind. So this is a spectrum chart. Keep in your office practice, keep the spectrum chart. For what bacteria, what is the best antibiotic spectrum? If you keep the chart, it's easy for you to choose antibiotic according to the spectrum, what is going on. It's very easy for you to choose. That is very easy. Then pediatricians are good compared to the adult physician. This is I wrote it to the adult physician group because they write random. For example, Cefixime means what they do, they write 200 milligram BD. But pediatrics are giving more doses because we need to give minimum 15 mg to go up to 20 milligram per kilogram of the body weight. So always go by milligram per kilogram of the body weight. That is most important thing. We are good. So we need to know how to use the antibiotics, the dosing, maximum dose. So don't think this dose will not tolerated by the child. No, maximum dose is required dose. For example, if you are using Cefixime means 15 to 20 mg per kg of the body weight. If you are using amoxicillin means either 45 to 60 or you can go up to 90 milligram per kilogram. Of late, couple of papers shows low dose, even 45 milligram to 60 milligram is fine instead of 90 milligram. The most important thing I already discussed, whether the antibiotic will reach particular part. Meningitis means whether amoxicillin will reach or not. Ampicillin has got good penetrations. Similarly, ciprofloxacin will penetrate. On the other hand, if you are using an antibiotic like nitrofurantoin for upper UTI, it won't. But in the lab, it will work. Microbiology lab will say E. coli sensitive to nitrofurantoin. But the child has got fever, chills, and rigor. Fever, chills, rigor means it's upper UTI. Lower UTI only urgency, hematuria, lower abdominal pain, frequency will be present. But there is no fever in lower UTI. Upper UTI means fever. In presence of fever, we need to use nitrofurantoin. If you think the child has got osteomyelitis or bone and joint infections, we need to go with clindamycin. Clindamycin has got good skin and soft tissue penetrations, penetrate the bone well. So we need to remember this pharmacokinetics and pharmacodynamic to choose our antibiotics. The most important thing now, durations. The duration is coming down, 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 short is sweet. For example, CAP 3 to 5 days. Even hospitalized child, ventilator-associated pneumonia, previously I used to treat for 15 days, but now it's 8 days. Pyelonephritis, again 10 to 14 days, now 5 to 7 days. Intra-abdominal infection, following some abdominal surgery, appendicitis or perforated appendix, the child start taking food. The child bowels are opening up. WBC count normal, no fever. You can stop the antibiotic on day 3 to day 4, even for perforated, because the surgeon already washed the wound. That is taken care. The child is tolerating solid food. The bowel opening happening. Temperature is missing. WBC count normal. You can stop the antibiotics. Even for chronic osteomyelitis and septic arthritis in adult, we treat little longer. For pediatric, the duration is coming down to almost 3 weeks is fine. There's no need for giving for 6 weeks. 3 to 4 weeks is fine for child with osteomyelitis and septic arthritis. The duration is coming down. Even for TB, people are working on to get 4-drug regimen. That is working for only 4 months. They're trying on 4 months regimen now. And we need to know the side effects. For example, the orthopedic guys, for osteomyelitis and septic arthritis, they give linezolid for 4 to 6 weeks. It drops the hemoglobin of the child. Pigmentations can happen. Dark pigmentations can happen in the tongue. The child won't take food. So before write an antibiotic, think about the side effects. Similarly, people previously, they don't give fluoroquinolone. But of late, fluoroquinolone can cause not only the tendon, capillary tendon ruptures can happen. And we need to know the local epidemiology. What is the common infections? What season it is common? For example, right now, the COVID cases are slightly going up now. The Omicron is slightly picking up. Before 1 week, dengue is more common, influenza is more common, COVID is coming down. But still, compared to other parts of the world, Kerala is still reporting more cases of COVID. But still there also more of dengue, more of influenza, less of COVID. But last 1 week, the trend is slowly changing. Again, the COVID is start picking up now. So we need to know the trends. We need to know the trends and what is common bacteria present in my part. That is more important. So coming back, this is a history and tips I told. So write the syndrome, assess the stability, make a syndromic diagnosis. Above the diaphragm, think about gram positive. Below the diaphragm, think about the gram negative. Choose antibiotic based upon the spectrum. Whether the bacteria will cover gram positive, whether it will cover gram negative, whether it will cover anaerobic, whether the antibiotic will go into a particular place, and what is the side effects of the antibiotics. So your choice become easy. So this child, you are saying symptomatic therapy. Why symptomatic therapy? The rule 1, stability of the child. The child is stable. The child vital parameters is stable. Rule number 2, temperature recorded. Yes, temperature recorded. The child has got temperature. Rule number 3, what is the syndrome? Acute pharyngitis. What causes pharyngitis? Rule number 4, mostly viral. How to differentiate whether it's a bacteria versus viral? We need to know Centaur criteria. When the child has got purulent tonsils, enlarged tonsils, purulent, very high temperatures, absence of cough, the patient has got tender node. Out of 4 Centaur criteria, if 2 or 3%, at least we justify to give antibiotic to cover group A diabetic streptococci. Here the child has got less temperature, not more than 100, mild congested throat, no node, there is cough still present. So it indicates all towards viral rather than bacterial. There's no need for antibiotic. So this justification is needed. I use the Centaur criteria. Based upon the Centaur criteria, the child does not have any bacterial infections. It doesn't require any antibiotics. I just give symptomatic therapy. So the test depends upon the timeline. Always remember some of the useless tests like MAN2, Vidal don't do in your practice. So this is a simple algorithm we usually do in adult populations. We can extrapolate to the pediatric. Stability, what is the durations? For example, 0 day to 2 days. Mostly any investigation is not required for a stable child. When a child is sick, when the child is unstable, we need to do investigations and start antibiotic justified. This is what we need to follow, simple algorithm. Suppose a child presents with 15 days, 20 days fever, we need to go with where is the localization sign. The localization sign, or depending upon the investigations, we need to proceed and we need to tackle it up. That's more important. So the choice of IDPLs, assess the stability of the child, record the temperatures, listen to the patients or patient attenders. That's more important. Dig the history, keep minimal investigations, try to avoid antibiotic as much as possible in the OP settings. When a stable child, less than 2 to 3 days, no need for antibiotics. So a couple of principles, I show a couple of case studies here. 7-year-old girl presents with fever, abdominal pain of 1 week duration, almost day 8, day 9. Little bit of constipations initially and on and off some little bit of diarrhea now. On examination looking normal, but spleen tip just palpable. That came with the WBC count because the child has presented more than a week. Other pediatrician has the test, the WBC count, everything is fine. Now the platelet count is 1.98 lakhs, ESR is 3, urine routine 1 to 2 parcels, urine cultures 1000 colonies of E. coli. What antibiotic? Please go ahead and vote so that we can have discussions. What antibiotic you want to start for this child? Because 1 week old, 2 to 3 days or 3 to 4 days, I told even a stable child we don't want to start. But most of the viral infections by day 5 or day 7 they will settle. But right now the child is having fever on day 8 almost. Still the child is having fever. I have not seen any responses so far. What antibiotic? People want to know ASO titer. ASO titer is again useless to me. There is no point in ASO. If you think rheumatic fever based upon the other criteria, yes, it has got good negative predictive value, but positive predictive value is very nothing. So I saw a couple of responses for this child. Ceftriaxone, very good. So what's your diagnosis here? Before write an antibiotic, write the diagnosis. So my diagnosis here, 8-year-old child, 7-year-old child, 8 days of fever, along with some constipations, bowel involvement, normal WBC count, spleen tip palpable. So most likely the chances of either enteric fever versus mononucleosis is possible. So among the two, since the monocyte count is not great, on the other hand, eosinophil count is missing. When the eosinophil count is missing, neutrophil count is normal, WBC count normal, ESR is normal, most likely typhoid. So I need to go and ask the parents what sort of food the child is eating, whether the child is taking the water outside the home. So we need to elicit the history, how often the child eats outside, how often the child eats ice creams, how often the child eats pani puris. These things is very vital for me to pick out a thing. When I elicit the history, the parent told the child has eating habits is often eat outside food, particularly the favorite food is pani puri. So can you know the organisms based upon the sensitivity and which antibiotic you want to start? I have not given any choices here. So please type what is the choice of antibiotic for this child. I have not seen any responses. What antibiotic? This is a Salmonella typhi. With Salmonella typhi, what antibiotic you want to start? I have shown ciprofloxacin sensitive. So usually pediatrician, they don't like fluoroquinolones. Adult physician, they like fluoroquinolone like ciprofloxacin and ofloxacin. So usually it's not required, but the blood volume, what I'm teaching previously, depending upon the weight of the baby or depending upon the age group, even newborn, we can take 0.5 ml, 0.5 ml, 1 ml blood is needed. More than 6 years, treat like an adult, take minimum 5 to 6 ml of blood per culture bottle. So depending upon the weight, we need to take the blood cultures. That is most important thing. I like to see the response. Only one participant attended azithromycin you want to start. That's good. So usually for typhoid, we need to give all other things, either azithromycin, amoxicillin clavulanic acid, cotrimoxazole, cefixime, you can start. But one antibiotic, fluoroquinolone, is not working. The resistance to fluoroquinolone in Salmonella typhi is growing up. Of late, we are seeing resistance to azithromycin. We are seeing resistance to even cefixime and ceftriaxone is also happening. That's what we are seeing. So this is a sensitivity report. So we need to elicit the history, what food the child is taking, what sort of food the child is taking. That is more important for me to decide what antibiotic to start. That is very vital for me. And similarly, if you see the sensitivity pattern, naldixic acid is a precursor of ciprofloxacin. That is first generation fluoroquinolone. When naldixic acid is resistant, ciprofloxacin will not work. That is most important thing. And what is 100% working? Cotrimoxazole 95% is working. Ceftriaxone is 100% working. Azithromycin, previously there is no guideline, but of late the guidelines is available to check how to check the azithromycin. Either you can use monotherapy. If you want to cut down the symptoms earlier, we can use a combination therapy so that the child symptoms can come down. But with appropriate therapy, the fever will take minimum 5 to 7 days. Tell the parents, if I start typhoid, the fever will settle down on day 5 to day 7. Even IV antibiotic, oral antibiotic, combinations, monotherapy, the fever will take minimum 5 to 7 days. Previously, fluoroquinolone reduces the temperature a little earlier, but of late, fluoroquinolone resistance is very high, so don't use this antibiotic. Use an antibiotic. Tell the parents, please wait for 5 to 7 days. This is 4-year-old female child present with a history of fever, body pain of 4 days durations. CBC normal, urine routine normal, urine culture group 10 to the power of 5 E. coli. Started on amoxicillin clavulanic acid, improved. But the amoxicillin clavulanic acid was resistant according to the culture report. What will you do now? Whether you want to continue the amoxicillin clavulanic acid, or you want to change it to an injectable agent, or either you want to stop the antibiotic and review the child, or you want to get the full sensitivity report. What are you going to do now? Please go ahead and vote so that we can have discussions at the end. So this is a 4-year-old child, fever, body pain, but urine culture 10 to the power of 5. Initial sensitivity, amoxiclav is sensitive, but started amoxicillin clavulanic acid, the child showing signs of improvement. So what are you going to do now? So they want to stop the antibiotic and review, because the child's urine routine is normal. When the urine routine is normal, the chances of having UTI is unlikely. This is a 4-year-old child. Either the child himself give the history, or the parents can able to recognize it. The parent can able to recognize it. Amoxicillin clavulanic acid, again, the penetrations in the kidney is not great. If you don't have any other option, use as amoxicillin clavulanic acid as a 3rd choice or 4th choice. Don't put amoxiclav as a 1st choice for urinary tract infection. Before that, whether you want to treat like an UTI. Here there is no UTI, urine routine is normal. The child's symptom doesn't point to just urinary tract infection. This is fever, body pain, more of dengue to me, rather than the dengue within 3-4 days, the child fever settling down, not because of an amoxiclav, the fever is settling down. So we need to know these things before starting an antibiotic. That is more important. So the first commandment in ID is diagnosis is not everything. Diagnosis is the only thing. Write your diagnosis, ink your diagnosis. If you ink your diagnosis, that is more important. The germ is not important. The terrain where it is found. If you do wound swab, if you do throat swab, it will show some bacteria. It has got no meaning. Whether the patient, whether the child has got some symptom, that is more important rather than just bacteria present somewhere. That is not at all important. So examine the patients. Examine the patients, elicit the history. That is a mantra to get the answer. So UTI diagnosis, look the child, or the child passing urine, what is the facial expressions? What is the discomfort the child is having? That is most important thing. Rather than seeing the child, don't treat the culture report. Treat the child. Treat the child, that is more important. So this is a 12-year-old female child, recent hospitalization 2 months back. Complaints of a recurrent skin lesion like a boil-like thing, but improved with antibiotics, coming back again. I'll show the picture. This time the swelling is much huge one. What are you going to do now? So what are you going to do now? On examinations, now what antibiotic? If you want, I'll show the culture report also. So this is a culture report. Staph aureus. Can you tell which Staph aureus? This is methicillin resistant or methicillin sensitive? Can you go ahead and answer whether it's methicillin sensitive or methicillin resistant? Surgery, that's good answer, very good answer. So whether you want to do methicillin sensitive or methicillin resistant, insights. So people say this is MSSA, because there is usually we need to check cephalexin, or we need to check cefoxitin, we need to check oxacillin. When oxa is resistant, this is MRSA, or cefoxitin is resistant, we can call it as MRSA. But here, most of the lab, they won't mention it. That is why I said the lab is more important. Not only the specimen, not only the amount of the blood, the lab is also very important. We need to coordinate with the microbiologists. Most of the lab culture reports signed by the technicians or by the pathologists, not by the microbiologists. So identify the lab which is good in your locality, send the sample and discuss with the people so that your antibiotic choice. But before antibiotic, the most important mantra for this type of cases, we need to do the source control. Source control is going to help rather than antibiotic. That's a mantra I'm putting here. This is my last case here, 8-year-old child, diarrhea 3 times, watery, no fever, no vomiting, afebrile, hydration is fair, per abdomen it's soft. What antibiotic will you start? Diarrhea 3 times for 2 to 3 days is now going on. What antibiotic you want to start for this child? People are still active at 8:45. They're putting no antibiotics. Yes, the diagnosis is acute gastroenteritis. Mostly it is viral. How to differentiate virus versus bacteria? 1, fever, presence of fever, presence of blood in the stool, presence of mucus in the stool, or at least 6 to 8 times loose watery stools per day. needs some justification to start antibiotic. Otherwise, most of the time it's not required. If you rehydrate the child, give the hydration part, that is taken care. There's no need for antibiotics. So gastroenteritis, mostly viral. If at all bacteria, 4 things can common: Salmonella, Shigella, Campylobacter, Yersinia. All will taken care by your azithromycin. That is fine. But before antibiotic, whether viral or bacteria, depends upon fever, presence of blood in the stool, presence of mucus in the stool, or at least frequency. Based upon the thing, you can start antibiotic. So don't jump and start antibiotic immediately. So this is a mantra for antibiotics. So use the 4 rules. Write the diagnosis, take appropriate sample, daily check whether the antibiotic needed or not. At the earliest moment, stop the antibiotic, use the maximum dose. Before that, good history from the parents, listen the child, examine the child, look the child carefully, particularly for urinary tract infections. The history of passing urine is very important for you. Look for it. Before treatment, the parents can come with a big car. At the end of treatment, they go with the same car. They can't go with the rickshaw. So we need to know what test and what antibiotic. That is more important. One more important. Third COVID wave, people are thinking about children, but what the Omicron is doing so far across other country, the people who are not vaccinated, even though Omicron is a mild cough and cold, but for pediatric populations, it makes the child hospitalized. So even hospitalized with COVID, no need for antibiotic. That's a point. But be careful for Omicron. Children are going to hospitalize more sooner or later. That's the data from South Africa. That's the data from US. They're showing children are getting hospitalized because they're not vaccinated so far. Even in US, India, we are going to start next month only. So any help, ID is available everywhere across the world now. So you can use a tele-ID consults or even personal ID consults also to choose your antibiotic. This is what I tell. You fear the least what you know the most. If you know the most, if you know the antibiotic spectrum, if you know the antibiotic side effects, if you know the pharmacokinetics of antibiotics, you don't fear about the antibiotics, you don't fear about the infectious disease. When you don't know about this thing, that's a problem. When we don't know, we're going to suffer, so we go to fear about it. That's a mantra, we are suffering it. So antibiotics at the end of this talk, no antibiotics. People like to see rather than antibiotic at the end of talk. That's my mantra. That's a take-home message from my side. And Happy New Year. Something is waiting for 2022. We need to keep prepared for the thing. Not only the podcast, something is waiting for us. And please feel free. We got hands-on training. We got tele-HD services. Feel free to contact us. We're happy to take. And I sincerely thank the opportunity given by IAP Thrissur Champs Pediatric branch for giving this wonderful opportunity. And I thank Dr. Anand Keswan for inviting me and chairing the sessions. Thank you very much. And participants for answering. I'm happy to take a couple of questions.
Thank you, sir. Thank you for the wonderful session on combined session on antibiotics, pharmacology, microbiology, clinical scenario all together, and also really clinical scenario. I cannot see any questions in the chat box. 2 questions from my side, sir. Can you explain more and elaborate on short course antibiotics? Because a child with a sore throat, we are saying that we have to give 10 days antibiotic to actually means proven and bacterial sore throat. 10 days antibiotic. For a UTI, everything is proven. Below 2 years, you have to give 10 to 14 days antibiotic. For a meningitis, except a meningeal meningitis, you have to give 10 to 14 days. So what are the conditions you suggest? Why there is a change, such a drastic change? Because we are using for 7 to 10 days. Now we are saying that 3 days. So what are the strict recommendations for short course antibiotics?
Usually for most of the infection, the thumb rule is 5 to 7 days. That's the thumb rule we can put. Even as you rightly said previously, sinusitis, pharyngitis, if you see the guideline, they themselves mention about 10 days. But even for sinusitis, pharyngitis, otitis media, the duration is coming down now. Except few infections, you clearly point out meningitis, meningoencephalitis, we need to treat longer. If it is an infective endocarditis, we need to treat longer. Osteomyelitis, septic arthritis, we need to treat longer. Abscess, undrained abscess, we need. For example, liver abscess or some internal organ abscess is very difficult to train. We need to treat longer. Otherwise, most of the infection, the thumb rule is 5 to 7 days. Why previously 10 to 14 days? There is no data, but half late now, a lot of studies comparing short courses with the long courses. Whatever slide I shown, this is conducted based upon the RCTs, mostly randomized control trial they're conducting now with the short courses comparing with the long courses. For example, pediatric situation, septic arthritis and osteomyelitis, they conducted a good studies. Even 14 days of antibiotic for osteomyelitis and septic arthritis is doing well. So we need to know the organisms. If the organism is not very virulent organisms, and osteomyelitis does not require any drainage or something, we can treat shorter also for the pediatric populations. So except few indications, meningitis, endocarditis, septic arthritis, osteomyelitis, undrained abscess, we need to treat longer. Otherwise, most of the infections, the thumb rule of 5 to 7 days is fine nowadays.
Or some practitioners do like the paracetamol 3 days, antibiotic for 3 days. And now it is justified. So my second question is that a child with symptomatic UTI is a common scenario. It's not nothing great.
I got it, sir.
Yeah, and we are giving antibiotic, and we send this culture also. By the time the culture report came, this is resistant to that particular antibiotic, but child improved. Okay, can you explain something about in vitro sensitivity and how these things happen?
In particular, the urinary tract will happen because even though, as you rightly pointed out, there is a differences between the microbiology lab, what they're doing and what is happening in the body, in vivo, what is happening in vitro, in vivo, mismatch can happen. 70-30 rule we can call. Most of the time, matches between in vitro and in vivo, but sometimes it is working in the lab. In real life, the patient will not improve. Even though you start an appropriate antibiotic based upon the culture report, still the child will start deteriorating. One. And second scenario, the child is improving, but according to the lab, the sensitivity pattern is lessing. How to explain? One, the diagnosis may be something else. We are treating something one. Second, possibly the diagnosis is also correct, but the child is improving because some of the antibiotic I told you earlier, for example, the co-trim concentrations in urine is much higher. So even though it is resistant, when they put fixed concentrations of co-trim with the fixed concentrations of the bacteria in the lab, it won't work. But what happened in real life, the co-trim, the level reaches in the urine is much higher. So with the much higher concentrations and the bacterial load is minimal, it can overcome with, even though that is resistant according to the lab report. So this is a pattern called in vivo and in vitro. So depending upon the pharmacokinetics, that is why I said if you use co-trimoxazole, that's fine. But if you use amoxicillin clavulanic acid, even though that is sensitive, but sometimes the amoxicillin won't reach a sufficient level, 30 to 50% only going to reach the urine. That point of time, even though sensitive, but amount of the bacteria present is very high, inoculum is very high, that time fail also can happen. So this is very difficult to explain. So you need to go with the clinical parameter. And once a child starts responding, when the antibiotic is not working according to the lab route, please go back, relook whether your diagnosis is correct or not. One more time, you check your diagnosis and correctly treating or not. That's more important for me.
I request to give some comments by Professor V.K. Parvati. He is a strong practitioner of rational antibiotics and is a teacher who recommends all her students rational antibiotics. Over to Madam.
Congratulations, the team IAP, for selecting all the important topics in the series. And congratulations to the speaker for bringing out the all the points in a very good manner. And as you have mentioned in your first question, that self-auditing, that is very, very important, self-auditing. At the end of the day in your office practice, if you do self-auditing, you may not misuse antibiotics to this extent. That is one thing which I would like to say. And think before you ink your antibiotics. That's also very, very important. Thank you for the opportunity. And Happy New Year to all.
There's one question regarding COVID. I don't know whether it's worth reading. Now COVID in kids are rising elsewhere. Any specific symptoms for Omicron in kids for which kids are getting admitted?
Yeah, I got right now 3 or 4 kids suspected Omicron. How to suspect Omicron? You need to have the S gene deletion should happen, S gene dropout. So wherever the PCR is happening, because in Tamil Nadu now it's very difficult to do the genomic studies. So what I'm doing in one of the labs, if I send, they do all the 3 genes, S gene, N gene, and ORF gene. If N gene and ORF gene is present, S gene is missing out, indirectly I'm considering as an Omicron variant. Whatever I have seen, almost 15-20 cases I've seen in the last couple of days. Most of the children, people, particularly adult populations, most of the people are vaccinated. They behave like a common cold. They got more of cold, the more of running nose, stuffy nose block, and sore throat, and very low-grade fever, but body pain is still present. Taste and smell is reasonably preserved. So for adult populations, taste and smell is preserved. Don't expect taste and smell should go away, and more of common cold-like presentations. The same family, couple of children got admitted. So far, the children also doing well. They also got the fever. The fever is not great. 101, 102 is not there. Only 1 or 2 days, maximum 100, 101. Subsequent days 99. The children also complain of body pain and more of cough and cold, sore throat only is presenting right now. No taste and smell and lack of appetite is not missing it out. But look for the S-gene in the PCR report. We specifically ask which lab is doing the S-gene. Do the lab, check out whether S-gene is missing it or not. And most of them, they're doing well. But according to the South African data and according to the US data, more hospitalizations in pediatric age group are happening because there is not vaccinated group. So they're happening in hospitalizations. Even the pediatric data I've shown in the South African data, 0 to 4 years. Compared to the wild type, compared to the beta, compared to the delta, Omicron hospitalizations are slightly higher for Omicron. So we need to see closely how the pediatric population is going to behave with Omicron, since our vaccination is going to start in Jan, and that too 15 to 18. But other sufficient population of 0 to 15 is present. We are not going to deal that also.
Another one more question, COVID, sir. 2 doses of COVID is taken. What about booster Covaxin?
Ideally, the study showed, one of the study conducted in India that showed mixing the vaccines. For example, people taken Covishield, they taken with the Covaxin, the response is much better as far as antibody response is concerned. Even vaccine effectiveness also demonstrated is much better. But unfortunately, I do not know the technically advisory group. I hear Nagar, they are having some data. I do not know what data. It is not available to the public domain. They've gone through some data. Based upon the data, they are given a recommendations, continue the same. Covishield means Covishield, Covaxin means Covaxin. But what data available in public domain, people exchanging thing, the response is much better. But how long this effect is going to last, that is a big question. We need to wait and watch. The third dose, if I take, how long? But whatever cases I see in the Omicron, it's a breakthrough. They admitted in the month of April, May 2021 under my care, April 2021, not 2020. Within 5 to 6 months now, they're reinfected with Omicron. The S-gene dropout I'm seeing right now. So people are infected, they're vulnerable. People are taken 3 doses. One other case I see right morning, I saw Moderna vaccine taken in US, came to visit the parents, landed here negative. So during visit, he visited a lot of places. Before travel back, he checked again, S-gene dropout is missing. So 3 doses of Moderna, taken the booster also, not working. So 3 doses is not giving protection so far, but only prevents protections for hospitalizations, prevent death. For infection, it is not preventing it. So ideally, mix and match, that is better strategy. Mix and match is a better strategy. What strategy? Since the government is not allowing, you need to find your colleague who has taken Covaxin. You have taken Covishield. You tell you take Covishield, I take Covaxin, but record Covishield and Covaxin in the record. That's what offline I'm telling it. That's what we need to do it now.
Uma Devi wrote something about ASO titer. Uma Devi is here.
Yeah, I saw that ASO titer. Usually, acute rheumatic fever has got value, but again, it has got good negative relative value. If the patient child has got fever, joint pain, swelling, presentations of rheumatic fever, because the significant, even though titers patient about 290 or something is significant, but usually the other parameters also should present, like elevated inflammatory markers, typical migrating polyarthralgia should present. These are all more important rather than go with ASO titer alone. It has got good negative relative value. In newborns with sepsis, sterile CSF is recommended to give antibiotics for 3 weeks. If you think the child has got gram-negative meningoencephalitis, justify to give 3 weeks. If it is a gram-positive, most likely the meningitis is gram-positive. Of late, we have got a good PCR, meningoencephalitis panel, that will find out common bacteria, common viruses, and even it picked up cryptococcus also. That meningoencephalitis panel, we can able to identify gram-positive 2 weeks is fine, provided there is no subdural correction, there is no subdural empyema-like thing. Gram-negative, yes, usually we treat little longer, but otherwise newborn also 2 weeks for gram-positive, 3 weeks for gram-negative. If subdural corrections empyema, we treat little longer.
Dr. Ashok Kumar from Aluva, senior pediatrician from Dr. Ashok Kumar. Any comments? Ashok Kumar, sir? So we are seeing that there are so many cases of viral infection, near infection emerging like that. Why there is increased incidence of scrub typhus? It's maybe partly due to increased recognition, but more than that, what is the reason for particular scrub typhus?
So a lot of things people putting now the climate change is the reason for it, and people invading the forest and everything. So we come close to the thing. But as far as the scrub typhus is concerned, the knowledge levels has gone up. For example, in 2008, 2009, and compare a decade old now, the knowledge among the physicians, knowledge among the pediatricians, knowledge among everybody, now scrub typhus, particularly in the month of August, when the winter starts between August and February, people think about the scrub typhus. So, and particularly bushy area, people living in a rural part, not in a flat system, they always think about it, scrub typhus. One, the knowledge. Second thing, maybe because of the climate change, we do not know, that's a postulate only. And people are visiting and they do all sorts of hobbies. The hobbies is going to different places, trekking, visiting places. These are all the things make the vulnerability come in contact with the mite. When you come into contact with the mite, the risk of scrub typhus is going up. So that's what's happening now.
Any other comments from audience? Any other comments? So I think we have a wonderful session by Dr. Suresh Kumar sir, and also comparatively good attendance because of the more than 75 attendance were there. And now my personal behalf, I thank you to Suresh Kumar sir. Now I invite Dr. Srijit to propose official vote of thanks.
Thank you, sir, for inviting me. And this is our 11th session of Thrissur Talk series, and last in the year and last from the present set of our office bearers. So, so we end this year with a high note with a very excellent power-packed knowledge presentation from Dr. Suresh Kumar sir. So I thank Suresh Kumar sir for a wonderful presentation and for your time and coming to IAP Thrissur for our series. Thank you very much, sir. And I also thank Anandageshwan sir for moderating this session and also for arranging excellent sessions for us for all these seasons. And also in the earlier start, we are delighted to have our new elected president, Dr. Vijay Kumar with us for inaugurating this session. So I thank Vijay Kumar sir, and also thank the Deputy DMO, the Sadish sir, and my friend Dr. Shiva Prasad and Dr. Pavan for providing the felicitations. And also thank Riti Madam, our guide, our president for the last 2 years, for all the support given to us and for arranging all wonderful academics all for the last 2 years. So thank you, Riti Madam, for your support and encouragement. And also thank all the seniors that joined us today, particularly Parvati Madam for joining with us and for providing the comments. And I also thank all the delegates. We have almost 75 delegates for this program. So thank you for joining for this program. I hope all of you have a good time with us and hope you to join with us similar programs in this platform or in the physical platform in the next year. So have a great year ahead. Have a happy new year. And once again, thank you for joining us and have a great day. Thank you and good night. Jai Hind and Jai